don't like 2, we like 11. So now it's place of service 11. If you've had some people file some claims for you and you got denied and you don't even know why did we get denied? Take a look at what place of service you use. If you use 2, put the 11 back on there and ask for a reopening, and you'll probably get paid. And if you're not getting paid, let me know, okay? Because that was a confusing way to start with, where they didn't even get the place of service pinned down what they want. Does that make sense? All right. So the first one, this is what they came out with. This kind of put the brakes on me when I first was trying to use it. Was the 2-way audio and visual with CMS. The time, it seemed like a bit of time to be on the phone, and it was just so hard to get the video going with them. What a pain. And they do allow, though, on you can use time whether or not it's for counseling. So usually when you use time in the office, it has to be time of one-on-one counseling about their problem. It's not supposed to be just time while you're riding an ulcer. Whereas here, it's any time, not whether it's counseling dominates a visit or not. So they gave a little bit on that, which is nice. These are the modifiers. You do need that 95 on there, and now the place of service 11. And Debbie should be able to forward to this email too, just so you don't have to write down everything here and hand it to somebody that does your billing. And can waive the copay, but it's not required. So if they have a copay or a deductible or whatever. This is the newest thing. This is what I was like, we've got something good for the meeting. Some podiatrists are going to make some money on work that they're already doing anyway. So they waived the video requirement that was in this CARES Act. What a pain in the butt. Now they waived it. You can do audio only. These are the 3 codes. And look at that time, 5 minutes, and it pays a full 99212. 5 minutes. So, when it says 5 to 10, all I can see is the 5. I can't even see that 10. I can't come up with 5 minutes to talk to people about. I can, do everything I need more. But I would think that one's going to come up a lot for me. Maybe somebody that's long-winded and has a bunch of questions about their medicine. Maybe I'd be at, the 11-minute one. But it pays the full rate at 99213. So you get 5 people at the end of the day that they want their medicine refilled, that they don't want to come in. Line them all up and say their doctor's going to call you at this time when he's done with the clinic, and you start getting people on the phone and you document those first few things, saying who they were and that they understand it was a telehealth visit, and you get them on the phone for 5 minutes and you discuss what medicine they were taking and whatever. I would probably be using this a lot on, like, I do some gout management or neuropathy management, or some people that are on maintenance anti-inflammatories. I do a lot of medicine refill. I'll do it over the phone now. And ride in 90 days and talk to them at the end of 90 days. And you're getting the full rate. Before they weren't getting the full rate, so now you're getting the full rate of 212, 213, 214. You do have to use that 95. You do have to use that place of service at 11. That one little caveat down at the bottom, be aware of that though. Don't have somebody leave out of the office yesterday. Now they want to call you back and have a televisit. If they can't have been in the office in the past 7 days, and people will do that to you. They see you and talk to you again tomorrow. They couldn't have been in the office for the last 7 days, and they can't come in to talk to you on the phone and then come in tomorrow. Otherwise, your telehealth visit's not going to get paid. So kind of simple, but it'd be good to maybe keep up with that so you don't spend a lot of time at the end of the day. So Blue Cross Blue Shield Alabama, I hit on this one because it's kind of our major payer besides Alabama, besides the Medicare. They did extend the telehealth now through December 31st. The Blue Advantage, I think they're reeling it out 90 days at a time. So they extended it 90 days, which gets us calculated out to October 23rd. They may extend it again. I guess they're just reeling it out a little bit at a time for whatever reason. But the waiver on the cost sharing, whatever the patient's payment is, they'll have to pay it. They're not going to pay the full amount. So if they have a cost sharing copay, the patient will be responsible. Now you could waive it, but they're not going to pay it for you. So that's what the waiver was. They were going to pay it for you, but now you have to get it from the patient. Now some privates, I tried to get a printout on what privates want, what they don't want. Some want 95, some don't. That's the best thing I can tell you right now. If you're getting denied and you didn't use the 95 and you're going through Aetna or Cigna, which maybe if we're still doing telehealth next year, I might be able to get a whole spreadsheet of who wants what. I don't have that right now. Our main two payers, Medicare Blue Cross, got that covered, and I know 95 can be an issue, so if you get denied, you know, I want to look into, did they want that 95 or not? So then Blue Cross Alabama, they are doing it with audio without the video, place of service too, and Blue Cross Alabama, they don't want any telehealth, so you don't use the 95. So, I know it's kind of a lot to remember, but if you print it out, give it to whoever does the billing, you know, I'll make a little cheat sheet, so that's what I'm putting down. All right, so there's a new ABN form. I would think everybody here probably gets some ABN signed. What do you know, they didn't keep changing this form, and now it has an expiration date, so I know in 2023, if I'm still alive, I'll probably have a new ABN form for you. So if you can download that and print it out. We print them in advance, a stack of them. Anytime we do anything that's not covered by Medicare, we have them sign that ABN. Now, some things that are statutorily not covered, you don't have to sign the ABN, but to make it easier for my staff, if they're paying money that Medicare is not covering them, I have them sign that ABN, saying they understood it wasn't going to be covered by Medicare, and I think it's just easier. And we got a stack of them still at the office, and I guarantee you we're going to use them until they're gone. I'm not going to throw a pile of photocopies away just to have some new ones on the 31st. But we'll, starting on the 31st, any new copies, we'll print out this new one and use that. So I would assume y'all are having some ABN signed. You're supposed to. I think it would solve you some trouble if somebody complained. You can pull that out of their chart and go, look, you know, we totally explained it's not a covered service. And you're supposed to keep it for 6 years. So there's some different reasons of why things get denied. In our case, a lot of times it would be a non-covered at-risk foot care where they just don't meet the criteria. And I don't think we're going to be doing things experimental, investigational, but their diagnosis with just diabetes alone, and they don't have any circulatory problems or any neuropathic problems, they might not be covered, and that comes up for us a lot. We do a lot of people where they just don't meet the Medicare criteria, and we make them pay cash, and we have to go out and ABN every time. And right now, we're at the rate between $65 and $75. So they'll come in, I'll do the work, and then I'll tell them if they covered or not. If you're not covered, this is what I would do. If you come back, this will go to your chart. I put it right in the chart. Now, if they show back up and go, well, I thought Medicare covers it. Well, on this date, we told you you don't meet the Medicare criteria. This is what the charge will be. If you want it done today, you'll be paying cash. A lot of people remember nowadays, but occasionally they forget, and we'll have it right in their chart. That's what it would be. We'd have to sign the ABN. You don't meet Medicare criteria. You've got bounding pulses and whatever, and we'll make them pay cash. Also, we make people pay cash that want what we call the in-between visit. So somebody that seems to want to re-ulcerate and they can't wait 9 weeks, they got terrible calluses, I'll say, look, you know, you can keep re-ulcerating and Medicare will cover you for your ulcer treatment, or you can come in at 5 weeks and every other visit you'll be an ABN and they'll pay us $65 to $75 every other visit, and we'll take cash for that, and then when it's 9 weeks, then we'll make the coverage service under the at-risk foot care. These are, a lot of times we're using the modifier, we're using the GY or the GA. You can just read over that and in your printout. A lot of times we don't transmit a non-covered service, but we'll have the form in the chart. I actually put a GY on somebody for some orthotics that are not covered because the GY said they're not covered, and then Medicare paid it. And then the patient was adamant that, well, they must cover it. I'm like, no, they made a mistake. So we just don't even transmit it. I don't know that can be standard APMA advice, but I think if you have the ABN in the chart and you did the care, I think it'll be okay. So the reason why I hit on this a lot is I've talked to many podiatrists over the years, and I find a lot of guys, they don't want to get involved with this, you know, nail, callus building, and then they'll just build like a 99212, just get them in, get them out, and keep going. There's a huge difference in the payment of billing a 212 versus finding out if they're qualified and billing the nail and callus care. And even if you're surgeons and you don't do a lot of, you know, diabetic foot care, at-risk foot care, it does come up, and you really could get paid much better if you would know the system and knock it out of the park. This is the coding pairs of diagnosis, because it changed a little bit when we went to Palmetto. 11/7/2021, we used the B35.1 as a primary, I-7293 as a secondary. On all those other ones, we only use the I-7293. Of course, you'll need your 278 or 9 on that. The STAR diagnosis, I mentioned this before, you know, the STAR diagnosis, they have to be under that active care. I try and avoid that at all costs. If they can meet the criteria under the non-STAR, which the main one would be the circulation, I-7293, they don't have to be under active care. You don't have to find out when did they see the doctor, how long has it been. If you go down the neuropathy one, which is the STAR ones, I don't see how you could possibly do it. We tried to do it, and it's just very difficult to keep up with when did they see him. The patient doesn't even know. There'll be a zillion phone calls, and you have to do it over and over again the rest of their life. If you certify them, you're allowed to make the diagnosis under Palmetto, which was a big deal. Cahaba, they didn't want us making the diagnosis. We moved to Palmetto, you make your own diagnosis, you certify them as at-risk foot care, and one time ever, and as long as you use that 278 or 9, you're putting in your own stuff in that, and you're covered. This is the diagnosis linkings. So Medicare on 1155 through 57, you're only using that one primary diagnosis of poor circulation. With the nails, you're using the B35.1 as primary and I-7293 as secondary. But Blue Advantage, believe it or not, they want it backwards. They want to have the poor circulation first. And if you switch these, it'll kick it back. And if you get a new biller that all of a sudden, you know, hey, we're getting denied a lot, make sure they know that you have to link it this way. You have to, or it'll kick it back. And same with like Humana, they won't take under the CAC care L85.1. And I know there's a business here that does some medical billing for some people, and they were getting a bunch of denials, and I told them, look, stop using that L85.1 with Humana, do L84, and I think it went through without a problem. So it's silly because these are different companies, it's the same work, but they want it linked in a certain way, and if you don't know it, you're going to end up having a bunch of denials over just silliness. So that's why I keep printing that up. This same or similar, I think this is really going to start hitting our doorstep coming up pretty soon. And unfortunately, I didn't realize how it was going to work. So everybody has probably heard about this same or similar anything in the last 5 years from any supplier, not just from your office, but orthopedist that handed out a boot. If it's in the last 5 years, they're going to deny it, but they're denying it retroactively. See, I thought I would file it and it would be, okay, it didn't go through. Oh, geez, I didn't realize it. I'm getting recoups from 2-3 years later now that they looked into it and they realized, oh, we dispensed a boot and paid for it within the past 5 years, pay us the money back. So that, I think, is going to end up being kind of a problem because no one can remember, no senior's going to remember did they have a boot in the last 5 years. So there are a couple of portals. I think it's kind of cumbersome. 2 different portals you have to check, and these are the websites. There's a registration process. You'd want to use your Social Security number instead of their Medicare number because there's been some issue on that. I think it's going to be an issue. I think if you start seeing denials, you might need to put it in your workflow about handing out stuff that you might get denied because it's going to be painful to eat a whole bunch of boots in 1 year, and it's not your fault. Oh, I'm also a little practice management. Now, every time we do a night splint or a boot, I'm having to sign that ADN. And I tell them, look, are you sure you haven't had one in the last 5 years? Because Medicare's going to kick back. And no, I haven't. Okay, good, sign right here. And then if they kick it back, we'll pull that ADN out and bill them. Of course, if they're dead by then, it's a little tough. Okay, so this 59 thing comes up all the time, so I keep it on there. I'm hoping this is something that you guys could just forward to your billing staff or whatever. When you start doing these multiple procedures, you got to have it. It makes no rhyme or reason, to have a 59 on an ulcer, whereas the G code, which pays like $9, is the primary. It makes no rhyme or reason. You would think the most expensive code would be the primary, but it's not. It's just best to just have this kind of cheat sheet. But doing these combination of billings when you're seeing somebody for nail and callus, or 2 different ulcers, a full thickness and a sub-Q ulcer, you start really getting ahead of what like even the family doctors can do when they're doing a 214, 215. If you're doing a nail, a callus, an ulcer, and an office visit for neuropathy, you're blowing their doors off. But if you don't know the system, you're eating it over and over again, even though you're doing the work, and I hate that. I want every podiatrist here to make as much money as possible. You're legitimately doing the work. We're just getting jerked around by these insurance companies that are making this into a game. So I'm trying to explain it as clearly as possible so you can be taken care of the way you should. MUE's coming up. A lot of times I'll get calls from people and they don't realize it's the MUE that's kicking them out, and I'll end up having to go over it with them. It's medically unlikely edit, and Blue Cross doesn't follow. It makes it all that more confusing. So like if you do a splint, a posterior splint, 29515, for Blue Cross you need to bill the RT and LT, two separate line items, whereas under Medicare, you have to bill just one. So you did it on the right and left. You're only going to bill one code, 29515, but then the 50 modifier means there's two, and then you have to increase the bill. If you only bill just for one, they're only going to pay you one. If you don't increase the bill, they won't pay you the extra 50% for the second one. Seems very unfair, but that is exactly how they do it. These are some of the ones that are under the 50 modifier. I have them on my super bill, so that way it alerts me, oh, if I did a bilateral on this one, I need to bill it as that 50 modifier. This was this LCD that we got put underneath, and as I was reading it today, I should have wrote tarsal tunnel surgery or neuroplasty surgery, so the procedures on the left don't link it with the neuropathy diagnosis. Pick tarsal tunnel diagnosis or something more specific. If you do a tarsal tunnel release, that's what it really should have said on 28035. If you do these procedures, just don't use the neuropathy diagnosis for procedures. It's like an alarm bell for them to deny you. Get specific. Tarsal tunnel, nerve entrapment. Don't use neuropathy. There was the problem where a lot of people were billing for using the electric stim with a needle for neuropathy. Medicare doesn't believe that that helps, and so they're really after denying things that are done for neuropathy. Now you could do an office visit for neuropathy, write gabapentin or something like that, but don't do a procedure and link it to neuropathy. You're asking to get denied, and I don't like that. I want you to get paid. So, just a reminder, and this does come up, people call me up, I don't know why I'm getting denied. Well, if it's underneath this, if they're on home health, they're not going to cover that wound product. They got to get through home health. If they're on the nursing home, you can't not only do wound products, but diagnostic imagery or D&D. So you don't hand them out a boob when they're in the nursing home. If you know some bit about diagnostic imaging, there's actually a technical component and a physician component. The technical component, you could take a 73630 x-ray 3 views and break it into two line items, one with a 26 and one with a TC, and you could still get paid that 26. So let's say you accidentally took an x-ray on a nursing home patient because you didn't know they were in the nursing home. The daughter picked them up and brought them over, and mom's got a hurting foot, and you take a picture and then you realize, oh, they're in the nursing home. You could bill 73630-26, the physician component, and it'll still pay you a portion of the x-ray, but it won't pay the technical component because they're supposed to get the x-ray in the nursing home where they bring in a portable x-ray and take it there. And that's part of that combined billing where the nursing home gets paid a kind of a global fee. So you could still get paid something if you figure it out and bill it that way. We generally just try and not line our nursing home patients up for x-rays. The assisted living, you can bill that kind of stuff, but be aware they could also be on home health. And I think I took out the GW thing. If they're on hospice, you've got to put a GW modifier, and that has to go to Medicare. I don't know if this is something that has changed, but we've got denials where we put the GW on and send it back to Humana or back to Aetna. Even if they're on a Medicare Advantage plan, if they're on a hospice, then you have to send it directly to Medicare. So they might hand you their Humana card, but if they're on hospice, you put the GW and you send it to Medicare, not Humana. So this is where I was trying to tell you how you could do well if you learn the system. You got your family doctor over there or your cardiologist. How smart are they? Billing a 214, 215, they're doing great. If you got somebody with nail calluses and you're managing their gout or their neuropathy or their arthritic condition with NSAIDs, you got 182. So I'm hoping that comes up in your scenario somewhere, you're doing well. And these are legitimate services that you're providing, and I think there's a lot of people in our association that end up giving the care away because they don't know how to to get it to code, they can't get it right, and then they do a 212 or a 213, and they're getting skunked when they could be doing better and help pay their bills and, you know, pay their association, stuff like that. All right, this is Wednesday's case. Those are all Stryker products with a couple of Integra fault plates. The RT and LT for the X-ray codes, this Humana, I could talk a lot about Humana. I've had back and forth. It seems like they always have something new where they want to do a recoup. A couple of years ago, I got a recoup on X-rays because I wasn't saying what views that I took in the note, even though I had the views of the actual pictures. They didn't want to see the pictures. They said it's not in the note, and then they wanted to pay me zero and took a recoup, and I went around and around trying to stop that from happening. So if you would, please put in all your documentation, what views you ordered, what views you took, and maybe you won't get a recoup or a problem. I just got a letter in from Humana on an ulcer debridement where they want the money back because I put down that I debrided the ulcer through the subcutaneous layer using number 15 blade, which is a method of sharp debridement. And then they said, well, you didn't describe what technique you used. Well, I used number 15 blade technique, but it didn't say the word sharp debridement. I don't know if that's going to become an issue. I'm going to find out. Maybe I'll know by next year. But Humana's, I don't know what they got going on over there. But I would suggest, until I know what the answer is going to be, put in the words, and I'm about to change my template, sharp debridement, using number 15 blade. And usually once I figure out a problem, I just add it to the template so it's just one click. So that way I don't keep getting screwed, because I don't want that. All right. The consultation code, if all somebody's doing, coming in Blue Cross and you're just doing a visit, not an injection, I think you get paid more doing the consultation code. If you add a shot to the consultation code, they won't pay the shot. If you do a new visit and the injection, then they'll pay both. So I would weigh it out. If they're not going to get an injection, they are a consultation. Bill that consultation code, it pays you a little more. If you are going to do an injection, even if they are a consult, move to the new visit code and the injection, and then we always bill the J codes. Is, you know, why not? You're doing the work, and that's probably your highest paying combination. That was our Sharko reconstructor. That's that Variax 2 Stryker plate that we're on that Sharko on that one. So the BEG plans, you guys are probably seeing some of those the Obamacare plans. They get that grace period where you're supposed to keep treating them. So Blue Cross will actually pay, even if they stop paying that first month during the grace period. So if they're still in that grace period in the first month, they're going to pay you, but they're not going to pay you the second and third month while they're in the grace period, and we won't treat you. We just say, look, you got to come up to speed. You're behind. And the website will actually tell you when the grace period started, so you'll be able to tell, are they in the second or third month? And we just say, look, we can. So then be personal preference on that. That was a midfoot fusion with a Evans and vermicular vertical uniform fusion. And these are some of the websites you guys probably need to get to your staff on so they can look at that stuff. I was talking to Eric. I've been doing ankle surgery for a long time, peroneal tendons, ankle scopes, Achilles tendon lengthens, but I have to go to Florida because, you know, we got a big problem here. But I've always been able to get it paid, and I even encourage y'all, if you live on the peripheries of Alabama, they have this thing through Blue Cross, contiguous counties. If the county touches Alabama and that surgery center is closest to the person's home, you can take them across the state line, do it, it'll be covered under Alabama. Well, now that we have our own particular podiatry fee schedule, they've actually removed some of the codes for like ankle surgery. They're not even on the fee schedule. So it's become this new fight that I have about trying to get them to cover stuff that's in scope practice in Georgia or Tennessee or Florida all around us, but now they're denying us. This is a peroneal tendon repair where I tucked it underneath the fibula bone, and that's the new internal brace on the anterior talofib at the end. So it's going to be a fight, even if we get our scope practice change, is now to go through the process of renegotiating with Blue Cross Alabama, who is also controlled by people that are somewhat anti-podiatry, and I use the word somewhat very loosely. So it's something that I'm working on now, on trying to come up with all the other cases that I did through other companies to really put them on the spot as it's unreasonable, but hope it's useful. Let me make it very clear, I really love the profession. I really love you guys. I think you deserve every bit of attention and help that I could possibly give you. I think that you guys do work that other doctors don't even come close to matching. That the podiatrists are some of the most humble, hardworking, honest people, and I think we get a raw deal, and I'm going to advocate 100% even after. Any questions? Yes.
How often do you diagnose PPD? You said to avoid getting
That's the main one I use is the I-7293 arteriosclerosis lower extremity, and I make that diagnosis, and then I tell people they qualify for the at-risk foot care, and then every time I see them, I use that diagnosis, and they still have to meet the Q7, 8, or 9, and Q9 comes up a lot because it's fairly easy: decreased hair growth, thick nails, thin skin, edema, cold feet. That's 3 Ds and 2 Cs. That makes a Q9. And then I tell them they meet it. Now, if they have those class findings, but they have bounding pulses, I tell them, look, you don't qualify. I mean, it's the diagnosis of poor circulation and these findings. And I'm in Baldwin County. You got people coming down from Michigan where they're just scrambling for any patient they can. They qualify everybody. Oh, I see my doctor every 4 weeks to trim my toenails. And I'm like, not here. And it does put you sometimes in an uncomfortable situation that you're like, look, you don't qualify. And if they don't qualify, they don't. I make them pay cash, $65 to $75. And if they don't want it, I tell them, well then, I'm not the guy for you. I'm not going to be bending the rules. Does that answer what you're looking at?
I had contacted Palmetto before, and they had told me not to use the 50 modifier, that they kind of put the 50 modifier on certain things themselves. Have you?
Oh, they're putting it on for you?
That's what they told me, not to put the 50 modifier on, that it would.
Well, how do they know you got that you did too?
Well, on certain things, I guess, but they had told me never to put a 50 modifier, that they would always put that on there, that it would kind of clog the flame.
Okay. Okay, sorry. Okay, I just got to repeat the question. So you've had trouble with using the 50 under Palmetto. If you can get a denial and get it to me, I'd be happy to look at it with you. We are using it. I don't see how they would know you did 2 unless you put it on there, because you're not supposed to do units 2. You're just supposed to put that with a 50 modifier and increase the bill. If you could get a denial and you send it to me, I'd be happy to work it with you. But it is working in our office, so I know it's not just a constant problem. We are using it with Palmetto, and it is getting paid. So, and I will tell you this: if you get advice over the phone from Palmetto, or even really any company, always take that advice with a grain of salt. Oh my gosh, I've got, an answer. Okay, now I understand it. And go down that path from I know exactly what they said, and months into it, as I still get denied, oh, you call back, now you're going to get a different advice.
Yep.
Because a lot of times the person on the phone doesn't know why the computer kicked it out, because they're just looking at it and then they have information. They're not the ones that actually denied it. The computer denied it, and now they're trying to figure out why did it deny, and they're spouting information as to, oh, it's probably this, not necessarily the right information. So I got burnt bad one year where I knew I heard it myself on the phone, so I know exactly what they said, and then talked directly to Medicare. It doesn't matter. So if you don't think that answer's right, you might want to check it with me, or call back and get some, another shot at the apple on what exactly is the reason. So just be careful, because I've got one answer, went hard with it, and what a waste of time. Hey, Dan.
Do you do an annual exam with diabetic patients every year?
Yes, we do an annual diabetic. We have a lot of family doctors that refer to us, and I guess that's meeting their MIPS, so they want us to do the diabetic exam, and then I forward it to the doctor, and they're like, cool, now I'm meeting MIPS without having to do any work. But I'm not billing particularly an office visit under just a diabetic exam or screening. I don't put it down as a diabetic screening. Usually if they're coming in as a diabetic, I'm looking for something to link my diagnosis to, not just
We
diabetes.
started doing it, and we have so far gotten paid without any question, because I really don't have a diagnosis to put with it.
What code are you using, just office visit code?
Yeah, for that, and then I'm charging for my other two things, but if they take my notes, I've done the shoe exam, I've done the neuropathy, I've done musculoskeletal. I checked their shoe, their foot size, I've offered them shoes.
Yeah.
I've done, CDID. It's just, I don't have a way of coding yet. You know, the.
Well,
like
to
the
get that
locks,
office
there
visit-
used to be the locks, and I never did use that.
Right, and that was a trap. I would not do that. That's a pays terrible, you know, it's hard to keep up with. I wouldn't use that. But you could do an office visit. Obviously, you'll need that -25 to pay the office visit separately, and I'll tell you what all office generally does. If they're diabetic, we're looking for, do you have any signs of neuropathy? Do you have anything else that I need to discuss today? And I'll make sure I put that in there, and I'll link it. Most of them have fungus of some type. I might write an antifungal topical. If they have some neuropathy, even if they don't want treatment, I might give them some neuropathy advice and link it to diabetic neuropathy. I'm looking for something to separate what I did as far as procedures and what I did for the exam. And more commonly, I am filling out what we made up a diabetic exam form, because that helps those family doctors meet their MIPS, and they love getting it. You send it to them, and they're like, good, one less thing I gotta do, it's in the patient's chart. And I think it's a good business
So
manual.
if I'm doing it, I just need to say, are you having problems? And when they do, then I.
Yeah, put it in. If they got any kind of fungal issue, any kind of neuropathy issue, or any kind of bunion hematoma deformity, you don't have to operate it or give them a prescription medicine for it, but you can advise them about, you know, these are surgeries that can be done, these are shoe accommodations that can be done. You know, I guess if you get somebody that's perfectly healthy, you may end up having, but it just doesn't come up, so it's not been a problem for us.
Yeah,
Does that make sense?
that helps. It's been confusing.
Yep. You gotta get the -25 on that visit. So anybody having particular problems getting paid? Yes, sir.
Have your wonderful copies of your presentation as usual? Can we get them?
I didn't make copies, but Diane has it to email to you. Okay.
Who has it?
Diane. Debbie, oh, I'm sorry, Debbie. I got stuck on Diane. Ask her right there. It's Debbie. I got stuck. So, anybody having particular problems or they're screwing you? But please don't hesitate, if you think you're having a problem, if I can get a copy of the remittance, if I can get a copy of what you actually transmitted, because I get a lot of phone calls where they're like, I'm getting screwed, okay, send me stuff, and then I never actually get the remittance and what was transmitted. It's just so hard for me to work it up. But you never know, somebody else might have the exact same problem you're having. If we group it together, we're better. Okay? I appreciate you guys.